Welcome back to the deep dive. Today, we are wading into waters that, I'll be honest, usually make people want to run for dry land. We are tackling a topic that has a reputation and not necessarily a friendly one.
It definitely has a reputation. I think for anyone who has ever cracked open a nursing textbook or walked into a pharmacology class, this specific unit is usually the weed out week.
The chemistry hurdle.
It's absolutely the chemistry hurdle. It feels so abstract at first.
Exactly. We are looking at fluid and electrolytes and their volatile, high-maintenance cousin, acid-base balance. We are working off a comprehensive slide deck from a nursing course, NRBS 3510 to be precise, and this thing covers the gamut.
It really does.
We're talking plasma composition, the physics of how water moves across a membrane, the specific ways your heart stops if your potassium is wrong, and the delicate chemistry that keeps our blood from basically turning into vinegar.
It sounds intense, because it is. But I'd argue this is actually the physics of survival.
Okay, sell me on that, because to a lot of students, and I've been there, this just looks like a bunch of charts to memorize. Up arrows, down arrows, sodium is 135 to 145, potassium is 3.5 to 5. It feels like data entry.
It does, I get that.
The mission today, as I understand it, is to stop memorizing the chart and start understanding the machine.
Precisely. Because when you're standing at a bedside, you don't have time to mentally flip through a flashcard. You need to understand the mechanism. Think of it this way. The human body is basically a biological suit of armor designed to protect a very specific internal ocean.
The internal ocean.
We evolved from the sea, and we effectively carry that ocean around inside us.
Walking bags of salt water.
Pretty much. But that salt water has to be kept at an incredibly specific recipe. If the salt content drops by just a tiny percentage, your brain swells inside your skull.
Wow.
If the potassium shifts by a number so small you can't see it with the naked eye, your heart stops beating instantly.
That puts the stakes in perspective. So, managing fluids and electrolytes isn't just about hanging a bag of saline because the doctor ordered it.
Oh, not at all.
It's about maintaining the specific chemical environment that allows life to exist.
Exactly. It is purely about patient safety.
Yeah.
You can have a patient who looks relatively stable, they're chatting with you, but if their potassium shifts from 4.0 to 6.5, they could go into cardiac arrest mid-sentence.
That fast.
That fast. A change in a single number changes the electrical conductivity of the heart. So understanding this isn't just about passing the NCLEX, though obviously that's important.
Right.
It's about being the safety net. It's about realizing that when you see a specific symptom, the recipe of the ocean is off.
I love that framing. So here is our roadmap for the hour. We are going to look at the container, that's the fluids.
Yep, the container.
Then we'll look at the contents, the electrolytes, the spark plugs of the system.
Really important stuff.
And finally, we'll look at the environment, the acid-base balance. Let's start with the fundamentals. What are we actually made of?
We established we are salt water. In the source material, they break it down into solutions. You have the solvent, which is the fluid medium water. And then you have the solutes, the particles floating in it.
Like the Kool-Aid powder in the water.
Right. In the body, those solutes are the stars of the show. You have proteins. Albumin is the big one we need to remember. Glucose, and of course the mineral ions, which we call electrolytes.
And plasma itself is mostly water, right?
When we look at plasma specifically, which is the liquid part of your blood, it's 92% water.
92%. So blood is actually mostly water.
It is. The remaining 8% is where all the action is. That's the proteins and electrolytes. But here's where it gets interesting, and where the slides brought up a point about demographics. We usually say humans are 60% water, but that varies significantly based on who you are.
Right, the gender-mass connection.
It does. And this is the first trap people fall into with dosing. A 100-kilogram man and a 100-kilogram woman do not have the same amount of water in their bodies, even if they weigh the same.
Walk us through why that is. It's tissue composition, right?
Correct. It comes down to fat versus lean muscle. Skeletal muscle is rich in water. It holds a lot of fluid. Adipose tissue fat is hydrophobic.
It's water.
It holds very little water. Generally speaking, biological males tend to have a higher percentage of lean muscle mass, meaning they're about 60% water. Biological females who naturally carry more adipose tissue are closer to 55%.
So, practically speaking, women have a slightly smaller tank for fluids than men of the same weight.
Yes, and let's extrapolate that to the elderly. As we age, what happens?
We lose muscle.
We lose muscle mass, we gain fat. So an older adult might only be 45 or 50% water.
That seems like a huge deal for nursing.
It is massive. It means their margin for error is smaller. If grandma gets dehydrated, she crashes faster than a 20-year-old athlete because she has less reserve.
And on the flip side,
Conversely, if you pump fluids into her too fast, her tank fills up quicker, and you risk fluid overload. You have to be so much more careful.
okay, so we know the size of the tank varies, but the water isn't just sloshing around in one big hollow cavity like a water balloon. It's compartmented.
This is the 2/3 versus 1/3 rule that every nursing student needs to burn into their brain.
Let's unpack that.
The body has two main compartments. The biggest one is the intracellular fluid, or ICF. That's the fluid inside the actual cells.
Okay, inside the cells.
That accounts for 2/3 of your body's water.
So the vast majority of our water is locked away inside the trillions of cells we have.
Exactly. I like to tell students, most of the water in the body is useless to me as a nurse.
That's a bit harsh.
Well, clinically speaking, I can't touch the ICF directly. I can't stick a needle into a cell to hydrate it. It's in the vault.
Okay.
That leaves us with the extracellular fluid, or ECF. That's the remaining 1/3.
But the ECF is split up too, isn't it?
It is. And this is the second crucial distinction. Of that 1/3 that is outside the cell, about 80% of it is interstitial fluid. That's the microscopic goo between the cells.
Like the mortar between bricks.
Exactly. The remaining 20% of the ECF is plasma. That is the fluid inside your blood vessels.
So let me do the math here. If I start an IV on a patient.
You are dumping fluid into a tiny, tiny bucket.
Right.
You are putting fluid into that 20% of the 1/3. That is the only place we have direct access to, the intravascular space.
And we rely on physics to move it from the veins to the tissues and eventually to the cells.
Precisely. We are manipulating that tiny plasma compartment and trusting the laws of physics to balance the rest of the body.
And that brings us to the physics of movement. This is where I think people get tripped up. The battle of pressures. We have hydrostatic pressure and osmotic pressure. Can you give us the explain it like I'm 5 version?
Sure. Think of it as a push and pull war happening at the wall of every capillary in your body. On one side, you have hydrostatic pressure.
Okay, hydrostatic. Hydro means water.
Right. Hydrostatic pressure is the pushing force. Think of a garden hose with tiny pinholes in it. You turn the faucet on full blast. The pressure of the water pushes against the rubber and sprays out of the holes.
Okay, so in the body, that's the heart pumping.
Exactly. The heart pumps, creating pressure in the vessels. That pressure tries to force water out of the blood vessel and into the tissues. It wants to spray out.
So if hydrostatic pressure wins, we leak.
We leak. Now, on the other side, fighting against that, you have osmotic pressure, specifically what we call oncotic pressure in the vessels.
Okay.
This is the pulling force.
And what creates the pull?
The solutes. Specifically, the big proteins like albumin. Imagine inside that garden hose, floating in the water, you have millions of tiny, dry sponges.
The sponges are the albumin.
Yes. Those sponges want to hold onto the water. They suck it in. They prevent it from spraying out the holes. They pull water into the vessel.
So hydrostatic pushes water out, and osmotic or oncotic pulls water in.
And fluid movement is just the net result of that war. If everything is balanced, you have nice flow. But let's look at pathology. If hydrostatic pressure gets too high, like in heart failure, where blood is backing up and pressure builds, the push wins.
And fluid gets pushed out into the tissues.
Hello, edema, swollen ankles. Now look at the other side. What if you lose the sponges? What if a patient is malnourished and their liver stops making albumin?
The pull is gone.
The pull is gone. The water can't stay in the veins. It leaks out. This is why you see children with severe malnutrition, kwashiorkor, who have those distended bellies. That's not fat. That's fluid that leaked out of the vessels because there was no protein to hold it in.
That makes so much sense. It's all about that tug of war. If you understand the physics, you understand the symptom.
Exactly. You stop memorizing edema and start understanding pressure imbalance.
Let's move to part 2. Fluid volume disturbances. This is when the container is either too empty or too full. The slides make a very specific distinction here that I think is often missed in casual conversation. The difference between fluid volume deficit, or FVD, and dehydration.
Most people use them interchangeably. Oh, the patient is hypovolemic, they're dehydrated. But in a clinical setting, specifically regarding the labs, they are different beasts.
Okay, distinguish them for us.
Fluid volume deficit, or hypovolemia, is when you lose extracellular fluid volume, but the ratio of water to electrolytes stays about the same. It's an isotonic loss.
So you're losing the soup, both the water and the seasoning.
Exactly. This is hemorrhage, this is vomiting, this is diarrhea. You are losing everything together.
Ah.
The concentration of sodium in the blood usually stays normal, because you lost the salt in the water.
And dehydration.
Dehydration technically refers to the loss of water alone, leaving the solutes behind.
So the soup boils down and gets salty.
Perfect analogy. The water leaves, the salt stays. So the hallmark of true dehydration is hypernatremia, high sodium.
Why does this distinction matter for the nurse?
Treatment. If someone is hypovolemic, FVD, they need volume. They need isotonic fluids to fill the tank and get the blood pressure up.
Right.
But if someone is truly dehydrated with high sodium, you have to be careful. If you dump water in too fast, you shift that sodium balance aggressively and can cause brain swelling, a much more delicate process.
So always look at the sodium level to tell the difference.
It's your best clue.
Let's stick with fluid volume deficit, FED, for a minute. What causes this? Aside from the obvious stuff like vomiting and bleeding, the slides mention third spacing.
Third spacing is a tricky concept for students. We talked about the two main spaces. The cells, that's the first space, and the vessels, the second space.
Right.
Third spacing is when fluid moves into a space where it does you no good.
It's not in the cell and it's not in the vein.
Right. It's trapped. It could be in the abdomen. We call that ascites. It could be in the tissues after a severe burn. The patient looks swollen. They look like they have plenty of fluid, but their blood volume is actually critically low because all the fluid left the vessels.
So they are intravascularly dry, but interstitially wet.
That's the phrase. And that is dangerous because their blood pressure will tank.
So let's play detective. You're the nurse. You walk into the room. What does the patient with FDD look like? What are you seeing before you even look at a chart?
You're looking for acute weight loss. That's the most sensitive indicator of fluid change. 1 liter of water weighs 1 kilogram.
Okay.
If a patient lost 2 kilograms overnight, they lost 2 liters of fluid, period.
What about the physical exam?
Look at the skin. Skin tenting. You pinch the skin over the sternum or forehead. In a healthy person, it snaps back. In FVD, it stays stuck up because there's no turgor. There's no moisture in the skin.
Cool and clammy.
Yes. The body is in survival mode. It says, I don't have enough blood. So it shunts blood away from the skin and extremities to protect the heart and brain.
The core.
Exactly. So the patient gets cool extremities.
And the neck veins.
Flat. If you lay a patient down, you should see their jugular veins. In FED, they are collapsed. The pipes are empty.
And the vital signs, the body is trying to compensate.
Right. The heart is working overtime. The tank is empty, so the heart pumps faster to try to circulate what little blood is left. You get tachycardia, increased pulse.
Why?
But despite that, the blood pressure goes down. Hypotension.
Especially when they stand up.
Orthostatic hypotension. They stand up, gravity pulls the blood down, there's enough volume to pump it back up, and they get dizzy or pass out. Classic sign.
Now let's look at the labs. The slides mention a specific ratio, the BUN to serum creatinine ratio. This seems to be a favorite NCLEX topic.
It is a classic. Normally, the ratio of BUN, that's blood urea nitrogen, to creatinine is about 10 to 1.
10 to 1, okay.
When the body is dry, hypovolemia, the kidneys aren't getting enough blood flow. They go into conservation mode. They start recycling urea. So BUN goes up.
And creatinine?
Creatinine is a metabolic waste product of muscle. It stays relatively steady or rises slower. So that 10 to 1 ratio shoots up to 20 to 1 or higher.
So if you see a BUN of 40 and a creatinine of 1.2, that gap screams dry.
Exactly. It tells you the kidneys are thirsty.
What about hematocrit?
It goes up. This is hemoconcentration. Go back to your soup analogy.
Yeah.
If you boil off half the water, the vegetables look much more crowded.
Right, the percentage is higher.
In FED, the water is gone, so the percentage of red blood cells relative to the liquid looks artificially high.
Okay, so we've identified it. How do we manage it? What is the nursing action?
It depends on severity. If it's mild, oral fluids, drink some water. But if it's severe or acute, we need IVs. And the choice of fluid matters immensely here.
The slides say isotonic electrolyte crystalloids are first line.
That's a fancy way of saying lactated ringers or 0.9% sodium chloride, which we call normal saline.
Okay.
These solutions have the same concentration, the same osmolality as our blood plasma.
So they stay where we put them.
Exactly. If you put isotonic fluid into the veins, it stays in the veins to boost blood pressure. It doesn't run off into the cells immediately. It fills the tank.
When would we switch to something else?
Once the blood pressure is stable, the doctor might switch to a hypotonic solution like 0.45% sodium chloride, half normal saline.
Or watery.
Right. It helps push some fluid back into the cells if they're dehydrated. But you never start with that if the patient is in shock because it leaves the vessels too quickly.
Got it. And monitoring.
Strict intake and output, I and O. You need to know every milliliter going in and coming out, sometimes hourly.
And mental status.
Always mental status. If the brain isn't getting blood, the first sign is confusion or restlessness.
Let's flip the coin. Fluid volume excess. Hypervolemia. The tank is overflowing.
Right. This is an isotonic expansion of the ECF. We have too much water and too much sodium retaining it.
What causes this?
Usually organ failure, kidney injury. You can't pee it out.
Right.
Heart failure. The pump is weak, so fluid backs up. Cirrhosis of the liver. Or, frankly, iatrogenic causes.
Iatrogenic meaning we did it.
We did it. We ran the IV too fast. We gave a patient with weak kidneys too much saline. We drowned them.
That's a sobering thought. What does this patient look like?
The opposite of FVD. They have edema, usually pitting. You press your thumb into their shin, and the crater stays there.
You can measure it, right? The pitting scale?
Yep, 1+ to 4+. You can even measure the extremity with a tape measure to track it.
And the neck veins?
Distended, JVD. They look like ropes on the neck because the pressure in the right atrium is so high, it's backing up into the jugulars.
And the lungs. This is the scary part.
This is the priority. Crackles. You listen to the bases of the lungs and hear that popping sound like Velcro being pulled apart.
Oh.
That is fluid backing up into the alveoli. They're literally drowning from the inside.
They'll be short of breath, coughing.
Dyspnea. Their oxygen saturation will drop.
And the vitals?
Sounding pulse.
Yeah.
It feels strong and thumping because the volume is high. Blood pressure is usually increased.
And the labs show hemodilution.
Right. The soup is too watery. The BUN and hematocrit drop because they are diluted by all the excess fluid.
So management here, stop the fluid.
Stop the IV immediately. Discontinue any sodium-containing fluids. Restrict sodium intake. Remember, sodium holds water.
And diuretics?
And usually diuretics. Meds like furosemide Lasix.
To make them pee it out.
Exactly. You are forcing the kidneys to dump the excess volume.
And positioning.
Semi-Fowler's position. Sit them up. If they're lying flat, all that fluid rushes to the chest and compresses the lungs. Gravity's your friend here. Sit them up so the fluid pools in the legs, not the lungs. It helps them breathe.
Okay, that covers the fluids, the container. Now let's get into the contents. The electrolytes. The slides call these the spark plugs.
It's a fitting name. These aren't just nutrients. They're charge ions. They conduct electricity.
Yeah.
Without them, your brain is just a bowl of gray jelly. It can't send a signal. Your heart is just a lump of meat. It can't beat.
We have a big 4 here, plus phosphorus, but I want to focus on the 2 heavy hitters first. The king of the outside and the king of the inside. Sodium and potassium.
The inseparable duo. And in many ways, they are mortal enemies.
Let's look at sodium first. Na+, normal range. 135 to 145 milliequivalents per liter.
Sodium is the king of the ECF. It is the most abundant electrolyte outside the cell. And we already established the golden rule. Where sodium goes, water follows.
Right. But clinically, when you think sodium, what organ should you be thinking of?
Brain, neuro. Sodium imbalances mess with the brain first.
So, hyponatremia, low sodium, below 135. Why is this dangerous?
When sodium in the blood is low, the blood becomes dilute. It has low osmolality. Physics dictates that water wants to move to where the salt concentration is higher.
And that's inside the cells?
Where is it higher?
Inside the cells. So water rushes out of the blood and into the cells.
Exactly, including the brain cells. Your brain cells swell up like water balloons.
But the brain lives in a box. The skull, it has no room to expand.
That's the problem. The brain crushes itself against the bone. That's why the symptoms start with a headache. Then altered mental status confusion. And if it gets severe or happens too fast, acute hyponatremia, you get seizures, status epilepticus, and coma.
That is terrifying. So how do we treat it? The slides have a massive warning box here.
They do. The instinct, if you see low sodium, is to give sodium. Oh, his sodium is 115, let's get it back to 135.
Sounds logical.
And it's potentially fatal. If you raise the sodium too fast, the water rushes out of the brain cells so violently that the cells shrivel up. You can strip the myelin sheath off the nerves in the brainstem.
That sounds incredibly specific and bad.
It's called osmotic demyelination syndrome. It is irreversible. You might fix the number on the chart, but you've left the patient with locked-in syndrome, awake but paralyzed.
So the rule is slow.
Slow and steady. You nudge the sodium up, millimeter by millimeter.
Unless they're having seizures.
If they are seizing, yes, we might use hypertonic saline 3% and ACL very carefully to shrink the swelling quickly. But that is an ICU situation. You are watching them like a hawk.
What about the opposite? Hypernatremia, sodium greater than 145.
This is usually a water problem. The patient has lost water but kept the salt like we discussed with dehydration, or they ingested huge amounts of salt. We see this in near drownings in the ocean.
What are the symptoms?
Thirst. Intense thirst. The body is screaming for water.
Right.
A swollen, dry, sticky tongue. And again, neuro changes, hallucinations, lethargy, twitching.
And the treatment here.
Dilute the sodium, give fluids, but again, gradually. We use hypotonic solution like 0.45% NaCl or D5W dextrose in water to slowly bring the sodium concentration down.
Okay, moving from the brain, sodium, to the heart. Potassium, K+.
Potassium is the major intracellular electrolyte. 98% of it is inside the cell. The amount in the blood is tiny, only 3.5 to 5.0 milliequivalents per liter.
That is a very narrow window.
It's unforgiving. You have a margin of error of 1.5 units. With sodium, you had 10 units. Potassium is microscopic. And while sodium is the brain, potassium is the heart.
Why is the heart so sensitive to it?
It controls the resting membrane potential, the electrical charge of the cardiac cells. It stabilizes the cell so it doesn't fire until it's supposed to. It keeps things calm.
Let's start with hypokalemia, less than 3.5. Who gets this?
Nurses see this constantly because of diuretics. Loop diuretics like furosemide, Lasix are great at removing fluid, but they also waste potassium. You pee it all out.
And GI losses.
Also, patients with GI losses, vomiting, suctioning,
Symptoms.
think low and slow,
Yeah.
muscle weakness, fatigue, leg cramps are very common.
Like the heart.
The ECG changes.
You get flat or inverted T waves, the repolarization of the heart is delayed, and you might see a U wave, a little extra bump after the T wave.
And the slides mention digoxin. Huge nursing consideration. If a patient is on digitalis or digoxin for heart failure and their potassium drops, they're at massive risk for digoxin toxicity. The low potassium makes the heart more sensitive to the drug.
So you have to watch that interaction very closely.
Very, very close to.
So we treat it with supplements.
Dietary intake, bananas, potatoes. But for clinical hypokalemia, we usually need pills like K-Dur or IV replacement. And here's an expert warning that needs to be in flashing neon lights.
Go on.
Never, ever push potassium the feet push.
Why? What happens?
If you push a bolus of potassium directly into a vein, you will stop the heart instantly. It is effectively a lethal injection.
So it must be diluted.
Always diluted, always on an infusion pump. Never gravity, never push. It burns the veins too, so run it slow.
You know, hyperkalemia, greater than 5.0.
This is the most dangerous electrolyte imbalance. It's less common in healthy people because our kidneys are great at peeing out potassium.
Yeah.
But if you have kidney failure, renal failure, this is a daily threat.
The kidneys can't filter it.
They can't. So it just builds up.
Or if you crush a limb.
Right, trauma. If you crush a muscle, all the potassium hiding inside those cells leaks out into the blood at once. A massive sudden surge.
What happens to the heart here?
The cells become hyperexcitable, but eventually they can't reset. The ECG shows tall, peaked T waves. They look like the Eiffel Tower.
That's a vivid image.
The PR interval prolongs. Eventually you get VFib or cardiac arrest.
So this is an emergency. How do we drop potassium levels quickly?
If it's mild, we restrict the diet. But if it's high, we have a few tricks. We can give a medication called Kayexalate, which binds to potassium in the gut and makes you poop it out.
But that's slow.
Right. If the heart is in trouble, we use the cocktail.
Yeah.
We give IV insulin and dextrose or glucose.
Insulin for potassium.
Yes. Insulin unlocks the cell door to let glucose in, but it also drags potassium into the cell with it. It hides the potassium back inside the cell, lowering the blood level temporarily.
It buys you time.
It buys us time to figure out how to get rid of it for good.
Clever. Moving on to calcium. Ca++, the muscle stabilizer.
99% of calcium is in the bones. The serum range is 8.5 to 10.5 milligrams per deciliter, and it is regulated by the parathyroid gland.
Hypocalcemia, less than 8.5. What causes it?
Often it's after thyroid surgery. The parathyroid glands sit right on top of the thyroid. If the surgeon accidentally nicks them or removes them, calcium levels crash.
And the symptoms are classic neuromuscular signs.
Tetany. That means muscle spasms. Without calcium to stabilize the nerve membranes, they fire randomly. You have two name signs here that are classic exam questions.
Trostics and trousseaus.
Right, Schwazek's sign. You tap the patient's cheek, right over the facial nerve. If their lip or face twitches, that's positive.
And trousseau.
You inflate a blood pressure cuff on their arm and leave it for a few minutes. The hand will spasm and curl up. It looks like a bird making a shadow puppet. That's carpal spasm.
Wow. And management?
IV calcium gluconate. Seizure precautions. And watch the airway. If the throat muscles spasm, what we call laryngospasm, they can't breathe.
Hypercalcemia, greater than 10.5.
This is usually bad news. Malignancies. Bone cancer breaks down bone, releasing calcium into the blood. Or hyperparathyroidism.
Symptoms?
Groans, moans, and stones. Muscle weakness, which is the opposite of hypo, constipation, kidney stones, and confusion.
And we flush it out.
Fluids to dilute it, furosemide to pee it out. And we encourage mobility walking helps put stress on the bones, which signals the bones to take the calcium back in.
Next is magnesium, Mg++, the quiet helper.
Magnesium ranges 1.8 to 3. Oh, it's the sidekick. It usually follows potassium and calcium. If they are low, mag is probably low too.
Hypomagnesemia, less than 1.8. What's the big cause here?
Chronic alcohol misuse.
Yeah.
Alcohol causes the kidneys to dump magnesium. We see this all the time in the ER.
Symptoms?
Just like calcium neuromuscular irritability, twitching, tremors, Schwastek's sign again, and mood changes, apathy, depression.
So they can look very similar.
They can, which is why you always check all three: cal, mag, and potassium.
Hypermagnesemia, greater than 2.6.
Rare, unless you have kidney failure or you overdose on antacids or laxatives that contain magnesium, like milk of magnesia.
Symptoms?
Think sedated. Magnesium is a smooth muscle relaxant. If you have too much, everything goes limp. Flushing, hypotension, muscle weakness. The deep-tended reflexes disappear. You hit the knee with a hammer and nothing.
And if it affects the diaphragm?
Respiratory depression and arrest.
And then the antidote?
5-E calcium gluconate. It reverses the effects of magnesium on the heart and muscles.
Finally, phosphorus P.
Ranges 2.5 to 4.5 milligrams per deciliter. It's critical for ATP energy and red blood cell function.
And it has a seesaw relationship with calcium, right?
Yes. Usually if calcium is high, phosphorus is low, and vice versa. They inhibit each other.
So hyperphosphatemia greater than 4.5 is usually kidney failure again.
Right. The kidneys can't clear it. And since high phos means low calcium, the symptoms of hyperphosphatemia mimic hypocalcemia tetany, twitching.
And the treatment for that?
We treat it with phosphate binders, like calcium carbonate, given with meals to sponge up the phosphorus from food so it doesn't get absorbed.
Okay. We survived the container and we survived the spark plugs. Now, the final frontier, part 4, acid-base balance. The environment.
This is the climate control of the body, the pH scale.
This is usually where students start crying. pH, PaCO2, HCO3. It feels like doing algebra in a burning building.
It does, but let's simplify the machinery. Your body needs to stay at a pH of 7.35 to 7.45. To do that, it has 3 lines of defense. I like to think of them as the first responders, the specialists, and the heavy lifters.
Okay, walk me through that.
The first responders are the chemical buffers bicarbonate and carbonic acid pairs in the blood. They react in seconds. If an acid appears, they bind to it instantly to neutralize it.
But they get used up fast.
Right. They are a temporary patch, so you call in the specialists, the lungs, the respiratory system. The lungs control carbon dioxide, CO2. And here is the key concept. In the blood, CO2 mixes with water to become carbonic acid. So for nursing purposes, think of CO2 as an acid.
CO2 equals acid.
Got it. The lungs are fast. They react in minutes. If your blood is becoming too acidic, say you're in kidney failure, your brain signals the lungs, dump the acid.
So you start breathing fast.
Small respirations.
Yeah.
Deep, rapid breathing. You are literally exhaling acid, CO2, out of your body to raise the pH.
And the opposite.
Conversely, if you are too alkaline, you slow your breathing down to trap the CO2.
But the lungs can only do so much.
Correct. Eventually they get tired. That's when the heavy lifters show up. The kidneys...
The metabolic system.
The kidneys are the bouncers of the club. They control bicarbonate, HCO3, which is a base.
Yeah.
They can physically look at a bicarbonate ion and say, you stay. They look at a hydrogen ion, which is acid, and say, you get out, go to the urine.
But they're slow.
They take hours or days to clock in,
Yeah.
but once they are working, they are the most powerful regulator we have.
So when we look at an ABG and arterial blood gas, we are basically looking at a crime scene to see which of these systems is broken and which is trying to fix it.
Exactly. We look at the pH. Is it acid less than 7.35 or base more than 7.45? Then we look at the lungs, the PaCO2, and the kidneys, the HCO3, to see who matches the pH. That's the culprit.
Let's run the 3 scenarios from the slides. Scenario 1, metabolic acidosis. The pH is low, less than 7.35. The bicarbonate is low, less than 22.
So the pH is acid. The bicarb, which is the base, is low. That matches, so it's metabolic. The most common cause is kidney disease. The kidneys can't excrete acid, or severe diarrhea.
The mnemonic for this is?
Acidosis.
It's crude but effective.
It works. Diarrhea comes from the lower GI tract, which is rich in bicarbonate. If you have diarrhea, you are pooping out your base. You're losing base out the bottom, leaving you acidic.
Symptoms?
Headache, confusion, and those small respirations we talked about, the lungs trying to compensate by blowing off CO2.
Scenario 2. Metabolic alkalosis. pH is high, greater than 7.45. Bicarb is high, greater than 26.
This is usually from losing acid. Think about the stomach. It's full of hydrochloric acid. If you have severe vomiting or gastric suctioning, you are sucking the acid out of the body.
Leaving you with too much base.
Exactly. Symptoms here are tingling fingers, dizziness, and hypoventilation. The lungs slow down to try to trap acid, the CO2, to fix the balance.
Scenario 3. Respiratory acidosis. pH is low, less than 7.35. PaCO2 is high, greater than 45.
This is a ventilation problem. The patient isn't breathing enough. Hypoventilation, they are retaining CO2, retaining acid.
Causes.
Anything that depresses breathing. COPD is the chronic one, but acutely. Opioid overdose, so the patient stops breathing, CO2 builds up, they become acidic. Or pneumothorax, sleep apnea.
Symptoms.
CO2 is a vasodilator, so you get a headache, flushed skin, increased pulse, and confusion, a foggy brain.
And the fix?
Improve ventilation. Use bronchodilators, reverse the narcotic with Narcan, or put them on a ventilator like BiPAP, or even intubation if necessary. You have to get the air moving to blow off that CO2.
So we've covered the ocean, the salt, and the climate. What does this all mean for the nurse standing in bedside?
It means vigilance. The labs are great, but the patient tells the story first. The nurse is the one who notices the tented skin before the creatinine comes back. The nurse notices the peak T wave or the subtle confusion in an older patient before the code blue happens.
It's about seeing the connections. You fix the fluid, but you have to watch the electrolytes. You fix the acid base, but you have to watch the potassium.
Exactly. It's an ecosystem. You cannot touch one part without rippling the water in another. They're all connected.
Here's a final provocative thought for you to chew on. The body uses lungs, kidneys, and chemical buffers just to keep pH within a tiny 0.10 window. It works harder at this than almost anything else.
It's an incredible system.
When we intervene as nurses, when we hang that fay, when we push that Lasix, we are entering that delicate ecosystem. We hold the power to restore balance, but also to tip the scale. Are we helping or are we hurting?
That's why we learn the science, to be the safety net.
Check out Table 10.4 in your source material for those specific lab findings we discussed. Thanks for diving in with us.
Stay curious.
See you next time.